I'd like to welcome Dr. Reavis, who is at UC Irvine, to give the next talk.
Great. Thank you very much, Marina, and thanks, Saeed. It takes a true talented orator to discuss so enthusiastically basic science at 7:30 in the morning, so thank you for sharing your talents. So Marina asked me to discuss how tight is tight. Basically, in 10 minutes, answer the question, what size bougie should we be using for sleeve gastrectomy? And I can tell you with absolute confidence that I think I might possibly know, but I'm not sure. So I have no disclosures. So what's the fuss? Why do we need to know this? Well, sleeve gastrectomy, and one of the purposes of today's course, is the number 3 bariatric procedure in this country, following banding and bypass. There are over 240,000 bariatric procedures performed in the United States each year. And again, I was given the task of answering how tight is tight. Weight loss outcomes and sleeve gastrectomy with different bougies. So I think before I dive into the bougie discussion, just like Saeed was mentioning, I think we need to mention a couple of subjective variables, starting with staple line proximity. Just a raise of hands, how many folks out there who've performed sleeve gastrectomy staple very close along the bougie, very tight? So modest number. So I don't staple too closely, so there's a little bit of give. I'm a little worried about potential staple line failure and what I do in that situation, because I'd have to oversew and potentially have too tight a sleeve. A lot of the audience did not raise their hands, which means that they're using bougies and again, probably coming off the bougie a little bit, which again throws right into consideration. If you're using a certain bougie and one French is 0.3 millimeters, then you could obviously increase or decrease your actual French size sleeve by coming off or staying very close to your bougie. So the actual quoted bougie size in various studies may be quite variable, even if the number is objectively the same. Some folks oversew sleeve gastrectomies. A lot of folks use staple line reinforcement. I use a prosthetic staple line reinforcement. The angles of creating a sleeve gastrectomy, how close do you come along the angularis? How close are you coming along at the angle of His? Again, subjective issues that can result in stricture, stenosis, obstruction, potential leak. And then certainly there's always patients. We'd like to think we're operating on robots, but we're not. So some patients are compliant, some patients follow up, some patients do not. And we know that obviously impacts our outcomes tremendously. So get to the Bougie data, because it's the only objective thing that I can really discuss. There have been several case series in terms of individuals' experiences with sleeve gastrectomy. There are about 5 major papers, and I apologize to any major authors in the audience who have other series. Please feel free to discuss those during the discussion scenario. But I'm going to touch on each of these. The initial first 216, which is the first large series of sleeve gastrectomies described by Drs. Lace Serengel and Joe Sart in the San Francisco area, followed by Dr. Manish Parikh and Michel Gagne at Cornell. German experience, the second international summit on sleeve gastrectomy, as well as the Spanish registry, are ones we'll touch on. So the first 216, this was a series of 216 patients, 2-year data following vertical sleeve gastrectomy. These patients were non-randomized between November of 2002 and 2005. They are all patients that met standard NIH criteria for bariatric surgery, typically 5 to 7 firings of a 45 to 60 millimeter stapler, 3.5 millimeter height, along a 32 French bougie in all those patients, resulting in what was estimated to be about a 60 to 80 milliliter gastric tube, and sleeve is compared to other bariatric procedures for efficacy. Mean BMI is about 50. There were several patients that were in a very large group, greater than a BMI of 80, 6 or 2.8% 70 to 80, and 11% that were between 60 and 70. They had complications in 6% of patients, compared to 7.1% in lap band, and that's most likely followed out, not necessarily intraoperatively. Leaks were seen in 1.4%, certainly respectable, and reoperations in 2.8%. There were no conversions to open and no deaths. And overall weight loss was on par with duodenal switch and roux gastric bypass with the sleeve gastrectomy. This is kind of a famous barium esophagram that is in the article. And one thing you can appreciate, and Paul Serengel mentioned at SSAT a couple of years ago, is you can appreciate the sleeve is even smaller than the esophagus leading into the sleeve. And some fairly tight angles there, but these patients did well in terms of weight loss, but quite impressive radiograph. This is simply showing along the y-axis the BMI over time and the follow-up on the x-axis at 24 months, and you can see a steady decline with the sleeve gastrectomy patients in the green line, and this simply showing the same data but with excess weight loss, and then sleeve actually leading the way compared to the other operations at 24 months. So Bougie and estimated weight loss, the Cornell experience. This is with Manish Parikh and Michelle Gagne looking at sleeve and variable size bougies, which had been an initial part of gastric bypass and biliopancreatic diversion, but of multiple sizes. So this study was to determine if there was a correlation between weight loss and the size of the bougie during sleeve gastrectomy, usually leading up to these operations. So they retrospectively reviewed 135 patients between 03 and 06 with a mean preoperative BMI of 60. Now, nearly 80% of these patients were undergoing sleeve as the first stage of a two-stage operation with either gastric bypass or BPD 11 months later. And here's the data. So you can see that simply looking at 12-month data that the 60 French patients lost 45% of excess body weight. The 40 French had lost 51%. And at 6 months, you can see it's a very similar relationship. So there was not any statistical significant difference between the use of 40 French and 60 French in these groups. And this is actually reflected in several series that you see below with increasing bougie sizes with 32 up to 60 and estimated weight loss. What I think is interesting, and in the red box there, is the fact that you had two studies with bougie size of 48 with 6 months excess weight loss at 46% in one group and 72% in the other group, then 56 at 12 months and 83 at 12 months in the other group. Obviously, there must be something other than bougie size going on with these scenarios because these are talented surgeons, and I'm sure they didn't misread the size bougie. Commentary from Ro Rosenthal on the Cornell experience was that the issue here is that there is some long-term follow-up difficulty because most of these patients were staged before going to a second operation. And in his experience in South Florida, a 40 French bougie is fairly standard with a 0.7% stenosis rate. So we certainly can accept less than 1% stenosis rate. At least a 40 French bougie is not too tight. Now, the German experience was a prospective study in 120 patients. I have to give them credit, or at least confidence, in the fact that their first group they did with no calibration tube. And I think as human, they probably calibrated, or at least based on visualization, a bit large. Group 2 was calibrated over a 44 French, and Group 3 was over a 32 French bougie. All three groups were comparable. There were 2 early leaks. Estimated weight loss initially was similar amongst the groups, but 2 years following up, it was significantly higher in the estimated weight loss for patients with the calibrated sleeve. So basically, they said that you do need to use at least a bougie. However, it didn't matter too much between the two bougie sizes. Now, the Second International Sleeve Summit, there's a questionnaire that was distributed to the 106 attendees, representing 14,776 sleeves. Bougie size was actually a range between 16 up to 60. Dissection commenced either very close to the pylorus or up to about 10 centimeters out. Mean estimated weight loss was fairly good in the 60s up until about 4 years where it declined a bit. Staple line was reinforced in most patients. The leak rate was about 1%. Late stenosis was, again, less than 1%. Mortality was certainly acceptable, and it's simply felt that sleeve has a promising future. The Spanish registry was something that was determined by Spain to determine the mid and long-term outcomes of sleeve gastrectomy. They knew the short-term outcomes. Data was obtained from 17 centers representing 540 patients with a mean BMI of 48. Morbidity rate was 5.2%. Mortality, again, well less than 1%. Staple line reinforcement was actually related to a lower complication rate, most likely bleeding. Here's the data, and we'll just skip right to the 36-month scenario where you have staple line starting right at the pylorus with 70% excess body weight loss, and 3 to 5 centimeters off the pylorus, 73% excess weight loss. Again, not statistically significantly different, although you can see initially it started out quite enthusiastic towards a very distal sleeve starting right at the pylorus, but over time things kind of worked themselves out and things became closer. Again, 36-month over a 32 French bougie versus 38 French bougie is where you're able to look at the long-term data. And again, initially it looked like it favored a smaller bougie, but over time things became closer and closer. So there's obviously something more to it than just bougie size long-term. So hot off the press, the third International Consensus Summit for Sleeve was held last weekend in Miami. And to quote a couple of the very prominent surgeons there, the optimal bougie size, or to paraphrase, the optimal bougie size for maximal weight loss while avoiding a too tight sleeve is 32 to 36 French. Again, based on a lot of expert input, and remember, there's a lot of subjectivity here, but this is really accepted as probably being the way to go. Just two alternatives. One is potentially using an endoscope. This is a study out of Virginia looking at 29 French endoscope rather than a bougie. And basically you see a similar complication rate, similar weight loss over time. They felt, well, maybe an endoscope is safer, but we also know the complication rate using bougies is very, very low, but some food for thought. Also resected weight, and this simply looked to determine if the relationship between the amount of stomach excised and a patient's gender and preoperative height and weight may correlate. And they looked at 165 patients, 136 female, 29 male, between 01 and 04. And what they found, the empty weight and capacity of the resected stomach was measured intraoperatively after resection and afterwards. What they found was basically that males are taller. That's not too much of a surprise, that the empty stomach weight and capacity correlated both linearly over time. So there's a correlation between preoperative height, gender, and preoperative weight of the stomach removed. Basically, what you can take home from that is if you have a very large man, you do a sleeve gastrectomy and the specimen is small, it may be inadequate. Conclusion. Well, success of sleeve gastrectomy is dependent among a lot of interacting variables, and I really feel, and I think the data supports it, that bougie size at this time appears to be one part of a large multifactorial equation. So with that, thank you.